Great. With that started, once again, I want to welcome you today to the Medicaid Advisory Committee for Kentucky's Center for Health and Family Services. My name is Helen Dawson. I'm with the Altarm Institute and been supporting the work here that Kentucky's been doing. I appreciate everyone taking the time to be with us today, and I'm very excited to be walking through this with you. First off, we wanted to start with a couple housekeeping items. For those in person, just a reminder that when you're unmuted in the room, the microphones will be able to pick up side conversations. So just be aware of that. And we'll be able to see you as well. So please raise your hand when you want to speak and then speak loudly and clearly so we can all hear you on the line too. And then on Zoom, please do try to stay muted unless you have something that you wish to share. You can use the raise hand feature. It's in the reactions tab when you want to speak. And then we also ask, if possible, to have your camera on as it helps make us feel like we're in the room together. If you have any questions, you can always put those questions in the chat as well. We'll be monitoring that. Great. Today's agenda, it's been shared around. We will welcome you all and conduct a roll call for our MAC members. We will conduct voting for MAC leadership positions. We will approve the past meeting minutes from the January, March, and May MAC meetings. We will review the bylaws as they've been updated to align with the new regulations and vote those to be approved. We will have a report out from the DMS commissioner and walk through some TAC recommendations. We will have an open call for new business, time for public comment, and then closing with an ask for a couple next steps too on scheduling the rest of the MAC meetings. We are going to go ahead and start with a roll call for the MAC members. I will call out names, and if you're on the Zoom, we ask that you either unmute and say here or chat in that you are here. If you're in the room, please say that you are here as well. Dr. Sarah Moyer. Here. Kendra Marsh. Here. Susan Stewart. Heather Smith. Oh, did I hear that? Susan Stewart? Okay. Heather Smith?
Here.
John Dads? Dr. Kelly Evans?
Here.
Beth Parton? Matt Burchett?
Here.
Catherine Hanna? Philip Travis?
Here.
Justin Kolasa?
Here.
Nina Eisner?
Here.
Barry Martin?
Here.
Kent Gilbert? Mackenzie Wallace? Dr. Sheila Schuster?
Here.
Ronald Butler? Aisha Elam?
Here.
Brian Proctor? I see Brian on the list, so maybe he's having trouble unmuting. We can come back. Peggy Rourke? Right, Brian is there. I got a chat from him. Wonderful. Okay, Tanya Whitfield. Tanya emailed to say she may be listen only, so we do know that she is on the line though. Theda Simpson Mosby.
Here.
Emily Beauregard,
Here.
Eric Wright, Zach Hart,
Here.
Taben Harrington,
Here.
Commissioner Lisa Lee,
Here.
Dr. John Langfeld, Dr. Katie Marks,
Here.
Lisa Dennis.
Here.
Okay. Any of those that may have been in the room but missed calling? Yep, I see Peggy Rourke is here. Thank you so much for chatting. Anybody else able to chat in that was unable to unmute?
This is Beth Parton. I'm here.
Thank you, Beth.
This is Kathy Hanna. I am here.
Thank you.
This is
Hi,
Jerry
Dr.
Roberts. I didn't hear my name called. Am I listed on the official MAC roster?
Sorry, can I hear your name? Sorry.
Jerry Roberts,
Jerry Roberts. Okay, we can track that. Jerry Roberts.
representing Kentucky Podiatric Medical Association.
Wonderful. Okay, thank you. Yes.
I didn't hear you call John Lillybridge, the primary care tech.
We weren't calling for this, just for MAC membership.
Okay.
Yeah. Thank you so much though. Okay, wonderful. Well, thank you all for walking through that with us. Appreciate it. And we will look for any participants that may join us throughout the meeting as well to track that attendance. Okay, thank you. All right, so we want to go ahead and move us along. At this time, we'll just take a statement here to recognize any conflicts of interest. If you know that you have an existing conflict of interest and shouldn't participate in a specific topic, you're welcome to disclose it at any time. By staying present, you're acknowledging that you don't have any conflict of interests. But if you do believe that you have one for any discussion point, you're welcome to excuse yourself, either stepping out of the room or leaving the Zoom if you're on the call virtually, and then rejoining after that discussion point. So thank you so much, and feel free to, if you have any questions about that, you can chat us on the side as well. Okay.
We have
And
a
with that,
question. We have a question.
yes, of course.
Sheila Schuster here. It would be helpful if you had a written description of conflicts of interest.
Okay, I don't have one in front
Most
of me.
boards that require that, there's a form that you fill out. And I
Okay.
guess my concern is that Medicaid pays a lot of organizations that we represent. And so I want to be careful. I'm sitting here with the representative of the Kentucky Association of Health Plans, for instance. So what constitutes a conflict of interest for someone who's representing a provider that gets paid by Medicaid or a health plan that is under contract with Medicaid? I'm not sure I understand
Okay.
what's being used here.
Okay, yeah, so we can absolutely put more definition to that. I don't have the written definition in front of me at this time, but we can absolutely form that better prior to the next session, of course. I don't think there should be any conflicts today, as it's majority administrative items and some updates on requested ongoings at Medicaid. Okay. With that, I'd like to welcome Commissioner Lee to provide a few welcoming and opening remarks if you have them, or at this time.
Hi, thank you. Yes, thank you, Helen. So hello and good afternoon. I'm Lisa Lee. I'm the commissioner for the Department for Medicaid Services. I usually tell people a little bit about myself, and I know that I think I've spoken to almost every single one of you. But I am the youngest of 13 children from Hazard, Kentucky. I've worked in Medicaid for about 25 years. I started on the customer service line. So I really understand the importance of this program to our members and our providers. We currently serve 1.4 million individuals in the Department for Medicaid Services. Over 600,000 of those individuals are children. And we only have about 1.1 million children in the state overall, so over half of our children that live in the state of Kentucky are enrolled in the Medicaid Work Paycheck program. We have about a $24 billion budget, so we are a significant player in the healthcare landscape. We are the largest payer of behavioral health services in the state. We do have children-specific benefits. We cover more long-term care. We pay for about 70% of the long-term care costs in this state, and we cover services such as 1915C home and community-based waivers that most commercial carriers do not cover. So we do have a very important role in improving the health status of this state. And I appreciate all of your commitment and your dedication to the Medicaid Advisory Council and all the important work that we're going to do. This is the very first one that also contains beneficiary advisory council members or committee members. So we're very excited to have this mix of individuals to help us drive positive policy changes or help us evaluate what's currently going on in our program, to help us move forward in a way that improves the lives of those that we serve. But not only that, but that removes barriers for some of our providers, that ensures access to care. We have a lot of data in the Department for Medicaid Services. We have claims data for every single one of our members, so we can generate reports. If we need to look at information, for example, there's a specific policy you want to look at or some sort of utilization standards or utilization volumes, what are the most common procedure codes? What are the most common diagnosis codes? Where is the money going? How are we spending it? And how can we ensure that we are designing this program and we're making changes to the program that ensures it's going to be, that it's operated efficiently and effectively, and that it's sustainable for future use. And again, I think looking at the 600,000 children that we cover in this state, any investment in the Medicaid program is definitely an investment in our future. And I often say that the Medicaid program was created for our Medicaid members. That's currently 1.4 million individuals in the state of Kentucky. But we cannot take care of our members if we also don't take care of our providers and listen. So this committee is made up of providers, of other representatives with associations. It's made up of our members or individuals who are taking care of our members. So this is a very diverse group that will have a lot of input into insight into this program and what we can do to improve it as we go forward. And I truly, truly appreciate all of your commitment and dedication to this program. Thank you so much for being here. Helen?
Thank you so much. We appreciate that. And we will kick off into the meat of some of the administrative items we have today, starting with electing leaders for the MAC. For voting members of the MAC, those that I went through with the roll call minus the ex officio members, we will be conducting elections for the MAC chair, MAC vice chair, and the secretary. I'm going to, over the next slides, introduce those positions and provide a little bit of context for each of the roles, and then speak to the nomination procedure that we've done so far, how we're going to vote for this, and then we'll hold the voting for each position. Some general information about those. They'll serve from today through June. You can run for more than one position. However, if you're elected to that position, you cannot run for another one after. We will vote for chair, then vice chair, then secretary. Future elections, nominations for officers will be requested at the last fiscal year meeting. We anticipate that being around April, potentially in June as well, depending on the meeting schedule that we confirm later in this meeting today. Nominations will be sent to members 30 days before the meeting and when the election will take place. The MAC will elect a chair, vice chair, and secretary at the first meeting of the state fiscal year around July of 2026. If a quorum is present, and then those officers will serve a full year term. This is future elections. Today, we'll be electing the MAC chair that will serve through June 2026. They lead the MAC, speak for the MAC when needed, work with all the members on agenda creation, and work with DMS liaison to make sure that that's set to go and shared out ahead of the meeting date. They work with really the DMS liaison on preparing all the aspects of the meeting. They understand the MAC bylaws. They support communication across the MAC, BAC, tax, and the Medicaid program leaders. They recruit new MAC nominees when needed, working with the chair, working with the vice chair and the secretary for help with that. They support tracking meeting attendance with the DMS liaison, and they run discussions during the meeting and monitor those discussions to ensure they're respectful and on topic. They lead call for votes, and they lead decision-making when needed. The vice chair takes over the chair's duties if the chair is unable to attend a meeting, cannot finish their term, or resigns, understands the bylaws, and helps the chair when asked. The secretary conducts the roll call, similar to how I did at the beginning of the meeting. They support contact for members that were absent and encourage them to attend. They track meeting minutes during the meetings. They record the voting when we go through those procedures, if there is one, and then they again make sure to understand the follow the bylaws and help the chair and vice chair when asked. For voting today, since we are hybrid, we're going to have a couple ways of doing it. Everyone in the room is going to be voting for their preferred candidate when prompted using a slip of paper that Barbara has prepared for all of the positions. And then you'll submit that back to Barbara. Everyone on the Zoom will have a poll that I will launch, and you'll message, or if you can't use that poll, you can message me directly. Only voting members of the MAC should be voting. The candidate with the majority of 50% plus one, that's the majority, will be moved to approve for the position. But if only one person is running, there will not be a formal vote. We will move to a motion for that, to approve that member. And then we'll do this for each officer position. Any questions about that process? I did it kind of quick. Okay. As members of the MAC know, ahead of this meeting, I sent out a couple requests for self-nominations for positions. At this time, we've received a self-nomination from Dr. Sheila Schuster to run as the chair. At this time, there's no one no one else who has nominated themselves. However, if there's anyone in the room that would, or on the Zoom that would like to do so at this time, we do want to welcome that opportunity. Okay. Okay. I'm not hearing anything. So I do believe that with Dr. Schuster running unopposed, that we won't be having to conduct a formal vote. So we need to now move or make a motion for approval of that, for approval of electing Dr. Schuster to MAC chair. The formal wording for that is for someone to say, I move to approve Dr. Sheila Schuster for MAC chair. And then someone to second that motion.
I move to nominate Sheila Schuster for chair. This is Beth Parton.
Nina
Thank you, Beth.
Eisner, I'll second that. I'll second that motion.
Thank you, Nina. All right, so then all voting members, we're going to ask you to, if you approve this, we're going to ask you to say aye when prompted. And if you do not approve this, we'll ask you to say nay when prompted. If you approve Dr. Schuster to be elected and serve as the MAC chair for the remainder of this term, please say aye.
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 Any opposed, please say nay. Thank you. All right. So we have a MAC chair. Congratulations, Dr. Schuster.
Thank you very much.
Wonderful. Thank you. Sorry, moving too quickly here. Thank you so much. For vice chair, We have Dr. Beth Parton, who has nominated herself for the role to work very closely with Dr. Schuster in the next year to come, and supporting her and supporting sort of all the activities and sharing and performing her role and duties should she need to step in. We did not receive any other self-nominations for this role, but once again, I do welcome any at this time for those in the room or on the Zoom. Okay, hearing none, and I think seeing none in the chat, we will move to make a motion to approve this. Is there anyone that would like to make that motion?
This is Nina Eisner. I'll make that motion for Beth Parton for vice chair.
Aisha Elam, I'll second.
Thank you, wonderful. And we will do the same aye and nay voting. So for all voting members of the MAC, if you approve for Dr. Beth Parton to serve as the vice chair for this coming year, please say aye.
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 All opposed, please say nay. Okay, wonderful. Congratulations, Dr. Parton. We are very excited to have you serving together with Dr. Schuster.
Thank you.
Of course. All right, lastly, we do have the secretary. We did not receive any self-nominations for this role ahead of this meeting. So we do need to determine and have a individual ready to serve in this role through June of 2026. Again, this role participates by conducting roll call, doing this lovely job that I've been doing of supporting the votes and tracking who moves the motion, seconds the motion, et cetera, and tracks that information. And helps support sort of the meeting minutes and getting those out the door. And just supporting the chair and vice chair as needed.
And so Helen, just to clarify, the department will be providing some limited administrative support to the secretary.
Correct.
And so they won't be responsible for taking notes and all of that stuff, but there will be some administrative support. It's just serving as a secretary as Helen had described.
Correct, that is right. It's a lot of sort of in-meeting roles, which you'll be here anyways.
I'll nominate myself.
Thank
Sorry,
you, Aisha.
Aisha Elam.
Yes, you showed up, so wonderful. Any other self-nominations? Okay. Once again, we'll be no need to do a formal voting or poll because we have Aisha running unopposed. So do we have any voting member ready to make a motion?
I'll make a motion to nominate Aisha for secretary. This is Beth Parton.
Thank you, Beth.
And I'll second that, Kelly Evans.
Thank you. And for the last time for this part of the meeting, all of those who approve Aisha Elam to be the secretary of the MAC for the coming year, please say aye.
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 All those opposed, please say nay. Wonderful. Congratulations to our MAC officers. We appreciate your willingness to serve in this role and very excited to work with you for the coming months. So thank you so much. Okay, let's continue into one of our first elements of business here is approval of the minutes for the previous meetings. These were shared as material ahead of this meeting. I do believe in past meetings, there was not the quorum to move these forward or approve these. So, but we are at that point today. So we can go ahead and make these or vote to approve these.
Helen,
This
we have
is,
Ellen, we have a handout. Dr. Schuster.
Oh, so sorry. Yes, Dr. Schuster.
Yeah, I'm a little bit confused about why we're voting again to approve the minutes of January and March. Because they were approved, if you look at the March minutes, the minutes of January were approved there. And if you look at the May minutes, the minutes of March were approved there by the then existing MAC makeup. So
Oh, okay.
it doesn't make any sense to me for a new MAC, who many of whom were not even at those meetings, to vote again to approve those minutes that have already been approved.
Okay. The record that we had showed that the quorum wasn't met, but we can look back to correct that. So we can narrow this down to just the May minutes, which I don't believe were approved in July.
We didn't have a meeting in July. We were
Okay.
not allowed. We didn't fit it in before July 9th.
Okay. So we can just move to approve the May 2025 MAC meeting minutes. So for this, the motion would need to be stated again, that I move to approve the meeting minutes from the May 2025 MAC meeting. And we would need a second of that, and then the full group voting.
This is Beth Parton. I'll make a motion to approve the minutes from the May meeting.
Thank you, Beth.
I'll second.
Thank you. Who did we have the second from?
Barry Martin here.
Thank you. All right. All those in favor of approval, please say aye.
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 All those opposed, please say nay. Okay, thank you. Those are approved. All right, so now we are moving into the section on the bylaws, and to provide an overview on these, we will have a chance to go through any changes that were made to these, and any sort of questions from members that we would like to take back. The slides that I have here are highlighting what are the sort of changes from previous versions of these bylaws. These were made to align and be in compliance with the 42 CFR that we know as the more recent regulations that came into be, and for why this new MAC structure has been created. So as you likely know, member composition was defined a little bit more, including listing the ex officio members, organizational representatives, advocacy groups, and the inclusion of the 7 back members as part of the requirement. Current appointment procedures were changed. The current appointments are now considered new, and the term lengths have been decided by the commissioner. Subsequent appointments will be 4 years in length, and MAC members may not serve 2 terms in a row as part of the new CFR. Some officer positions descriptions have been updated or enhanced in the bylaws, i.e. the inclusion of the chair working with the DMS liaison to complete some duties, the secretary responsibility for tasks such as minutes and recording votes during meetings. The role of DMS has been expanded in compliance with the CFR, including the addition of helping the MAC members create the annual report that is required. In addition to those, guidelines surrounding public meetings have been established and written into the bylaws, including having at least 2 MAC meetings per year that need to be made public in accordance with the regulation. The MAC meeting cadence has changed to comply with the requirements, and the BAC must meet in advance of the MAC. Other information, including expanded language around the agendas and minutes, was included, as well as work groups. For awareness, which is different than what we just did, going forward, minutes will now be posted by DMS to the website within 30 calendar days of the MAC meeting in order to comply with the CFR. This is different from the, full voting procedure. So we will be working with the leadership to establish the protocols for approval of those minutes by leadership or posting to the website. So at this time, want to make sure we have time for any questions for what you read, any questions on what I just shared that we can try to answer now, or anything that we can take back as well.
This is Beth Parton. I have some questions or comments about the bylaws. I guess first of all, on the first slide, it said that the secretary will take the minutes, and we just assured the secretary that she will not have to take the minutes. So
Yeah.
we need to fix that.
Yes, yes. Yeah, absolutely. We can adjust. I think we can align sort of the expectations and work with the leadership to figure out exactly what we want to have in there. Whether it's we, work with the transcription services, we work with DMS staff to have like full notes from the DMS aligned with any like secretary notes, or if we just do not want to have the secretary take notes at all, we can figure out if that's best to remove or not. So if we want to fully take it out or not, we can.
The minutes have always been the transcript of the meeting, so maybe to try and be in compliance with the CFR, just say that the secretary will review the minutes to make sure that I don't know, that whatever, that they're okay. Of course, proper wording for that, rather than have her take the minutes.
This is Nina Eisner. I have a question about the meeting cadence. I believe it said that it will meet 2 times per year. That's only half of what we've typically met.
No, sorry, it's just the 2 times per year is the requirement that to be public.
And what's the difference in that?
The cadence is to be determined based on the scheduling. The cadence can be as frequent as you would like it to be, as long as you do not meet before the back meets. So you can meet I think you can meet every other month at this point, because the back has determined that they will be meeting every other month in 2026.
Thank you.
Yes.
I had a comment, that was another one of my comments, related just to what Nina said. I think that all of the MAC meetings should be public, not just 2.
Okay.
And then there was something new in the bylaws about the work groups being public. And I would suggest that the work groups be formed to not contain enough members to be a quorum, and that the work of the work groups not be required to be public. It makes it more difficult to, if there's a work group that has to work on a particular topic, they're going to be bringing that work back to the MAC, which will be public, and therefore they should be able to have their discussions and their work not be public, I guess, because a lot of that work is done through email, at least from my experience with the MAC, is done through email, and it's difficult to make that public.
Helen, this is Veronica Judy Cecil, Senior Deputy Commissioner for Medicaid. Just a couple of things. So we took the federal CFR language and incorporated into our bylaws, but every state's open meetings laws then apply. So while it says that only 2 have to be open to the public, if Kentucky open meetings law says that they all have to be, then that's what we're going to have to follow. The exception to that is the Beneficiary Advisory Council meetings. the federal law specifically says that the back meetings can be closed. And so that then trumps the state open meetings law. So for back, it's different. They can make theirs closed. And they can make all of theirs closed. None of their meetings have to be open to the public. The MAC is different. The MAC, the federal law wanted, because there were states, I believe, that didn't open up their MAC meetings to the public. And so they wanted to make sure that all states had at least 2 public meetings. So in Kentucky, we will have to have open meetings unless there's a reason to go into closed meeting during the public meeting that follows the Kentucky meetings, open meetings. And the work
Thank you,
group
Martha.
would have to be the same. We'll have to follow Kentucky open meetings law on the work groups as well.
Even if the work group is less than a quorum?
We'll have to, so we'll have to follow open meetings rules when there's a designation of a work group, we'll review it to make sure it's in compliance with Kentucky Open Meetings Act. So we can change the language just to say in compliance with Kentucky Open Meetings Act, and then we can go from there.
Okay, so there would be a possibility that if there was a small work group of maybe 5 or 6 people, that it depending on the topic, it might not need to be public. Would that be?
We would have to make that decision on a case-by-case basis. I don't feel comfortable just saying, confirming that those would be open or closed. I think that we're gonna have to navigate that with whatever the desire of the MAC is and in compliance with the Kentucky Open Meetings Act.
It is traditionally with the open meetings that goes in the closed session, if it's like personnel matters.
Right.
I don't know of anything else
Yeah.
besides that.
Yeah, lawsuits.
Yes, maybe a
personnel,
lawsuit, yeah, that would,
right.
yeah.
It would be unusual for the MAC to go into closed meeting, but
Yeah.
I don't think we've ever done it.
Yeah,
But I think the work group is an interesting case. If you've got a small group that's working on, a very specified topic and is going to report back to the MAC, I think it's worth running it by. So putting the language in that says we will be compliant with the Kentucky Open Meeting rules, probably is the way to go.
Yeah, I'm thinking about it. The last time that we had a work group which was a long time ago, was when we developed the bylaws. And that was just a very small group of people. And it would have been difficult to have that as an open meeting because there was a lot of different emails exchanged. It wasn't like we sat down every month and had a meeting. We emailed sometimes every other day, sometimes weekly, with different comments about moving forward with the bylaws. And so that would have been very difficult to have that as an open meeting.
Okay, so I think we will need to make sure that the Kentucky Open Meetings Act language is in the bylaws, noting that all meetings will comply with that, as that is the what needs to come first. And we'll review as work groups evolve, making sure that we align with the structure that the MAC wants and making sure that we're in compliance with it. Yep. Justin, I see your hand as well. So want to make sure you have a chance to ask your question or share your comment too.
Just wanted to comment on the minutes. Emily Beauregard also mentioned it. When we get these 2-hour transcripts, I find it, overwhelming. So if we could hit the high points on that, that would be very helpful. Sometimes these transcripts I get now, it's like I can't read through all this. So just hopeful we can do like a synopsis type minutes for the future.
Yes, I agree. And Emily, I see your hand up as well. Were you going to add?
I actually wasn't going to comment again on the
Okay.
minutes, but I agree. And to Dr. Parton's point about the work groups, I do think that they should be considered separately from public MAC meetings, partly because of, the nature of a work group meeting is very different. And you are bringing a smaller subset of members to discuss something. much more technical, generally speaking. So I wonder if there's a way to get to review both the open record rule that we have here in Kentucky, but also maybe get the input from CMS or ask CMS if they can better define what that means, because I think that we might be unnecessarily limiting ourselves in this case. And I just personally doubt that most people are going to want to participate in or observe these work group meetings. And I think that you can't have as much open conversation and discussion in that format either.
Yeah, it's a great point. And definitely something we can take back. I think that there could be opportunity to explore like what the best sort of interpretation of the regulation is to align with the MAC's preferred approach too. Additional comments?
We have a hand up, Dr. Schuster.
Yeah, I have a couple of things I went through on the bylaws on page 4, and it appears several times. If someone wants to be excused, they have to have the permission of all 3 officers. That seems pretty dramatic. And it's several places. It's up at the top of the page, and then it's again lower in that same page.
Mm-hmm.
Is that, where did that come from? I guess I'm asking. Is that something that CMS wants, or is that just something that somebody?
I think that came from a long time ago, where we were having a difficulty having a quorum. People just weren't showing up for the meetings, and that goes back maybe 10 years ago.
We've not had any problems with quorums.
No, we haven't. But I think that's where that came from. And it's probably archaic and needs to be changed.
How about if it says it excused if the chair and one other officer? I mean, it just seems fairly dramatic.
We can just do chair. It's up to you all. What
I'm willing to do it. Let's just do chair.
Plus, isn't there
or an officer, or an officer.
Or an officer.
and
Yeah.
isn't there language about if you miss so many meetings, you can no longer be on the council?
For an excuse.
Yeah.
Yeah.
Mm-hmm.
Yeah, can we just say an officer of the match?
Yep.
Right below that on E1, it says a member who wants to leave the MAC. I think we're talking about a member who wants to resign from the MAC. Leaving
I believe so, yes.
and then to fulfill a term.
Excuse me, back to the leave versus resign. Are you asking for it to go back to resign?
Yes.
Okay, I think that was a
Resign from the MAC must submit a written resignation to the chair.
okay.
Under the vacancies, if a member resigns, removes, or passes away, there's a replacement. Typically, the replacement would fill out that term and then start a new term of 4 years. But is that not permissible under the CMS rules for a term of 4 years? I mean, that's typically when you are elected or appointed, you fill out the term that's being vacated, and then you would be able to start that new term.
It doesn't disqualify. I think what you're trying to say, it doesn't disqualify you from being reappointed. Because the only time when a vacancy is filled, it's for the unexpired term. That's the general rule.
Right.
There might be circumstances where someone can be reappointed if they haven't completed a full term.
Right.
So if you're proposing to, if someone doesn't complete a full term, that they could be reappointed. I think we're gonna have to go back and see if that conflicts with what the federal requirements because you're still in a term, even if it's just a partial term, you're still in a term, and so we'll have to go back and see if that conflicts with the federal
Well,
regulation.
one of my concerns is because it's so strict about 4 years and then you're off for 4 years.
Mhm.
If you have somebody good who wants to serve, but there's only 1 year remaining in that term,
Yeah.
you kind of wasted that person, if you will. And that, you know, I would like for you to look and see, Veronica, if that's possible.
Sure.
You know, can they fulfill that term and it would not disqualify them from then being appointed to a succeeding 4 year term? Thank you. I didn't realize that MAC, is this new that MAC members could be reimbursed for travel?
Yeah, for mileage.
It's always been.
Yeah,
And it's
we
always-
did that prior to.
Yeah, how come I've been serving all this time? I didn't know that. Okay, so that's always been there, all right. On the next page about the tax. It says that the tax reports will be submitted to the MAC members before the meeting, and that's never been the case. I mean, it's a good idea, but it's really gonna take a change because the MAC, I think sometimes the MAC chairs forget about the PAC chairs forget about the MAC meeting and kind of rush in. They very often don't have the recommendation in writing, which is not good. So I guess all I'm saying is if we're gonna do this, then I think we really need to understand that we're gonna have to do a lot of educating of the tax and their chairs about the process, because it's really a dramatic change in the process. I think it's for the good, but I just am pointing that out.
Sheila, that's always been the case. It's always been in the bylaws, but we just haven't.
Nobody's ever enforced it or done it, okay. Well, shows you how you don't read your bylaws. I apologize for that, Beth, because I wasn't on that work group that came up with it. The annual report, I'm a little bit confused. Is there an annual report from the MAC and also one from the BAC?
So the annual report required by the regulation is actually the MAC, but it includes the BAC activities, and they both
Oh, okay.
work on it.
So it's one report.
It's one, but it's really under the MAC responsibility.
Okay, so the MAC takes the lead in pulling that
That's
together and then reports the BAC activities.
And of course, the department's gonna support all that work.
I have a question about voting because it appears several times. So you define a quorum as half of the members plus one. And then when you have a vote of a meeting where there's a quorum present, you list that 14 members are gonna have to vote for it, which doesn't make sense because it means that everybody who's in the quorum has to vote yes on the thing.
Quorum actually is, and we can clarify this, thank you for bringing that up, that's unclear. A quorum in Kentucky is established with the majority of the members that are part of the board or committee. It's not of who's present. So, which I know is something we've had a challenge with before we went to a hybrid or a virtual option, but so that means it's always going to be 14 for the MAC to be able to have a quorum.
But at the top of page 8, number 3, a decision passes if the majority of MAC members vote for the same option. So I'm trying to, just want to be sure that we're talking about a majority, half plus one of the quorum that's present at that meeting. Right?
No, a majority is always going to be 14 for this MAC. So we'll make sure that that's clear. You have to always have a quorum for voting for anything.
I understand that, but what constitutes the vote passing? What vote?
14 members vote for whatever the motion is.
So it has to be passed unanimously?
No, there's 26 voting members of the MAC.
Right.
14 of those have to vote yes.
But there's 14 present.
But if there's
Or it would be
14 present,
That's right. They would all have to vote yes. That's correct.
okay. That does make sense to me. how do people sign up if they want to make public comment? What's the process for that?
It just, there's no advance signing up. People just have to either join the MAC meeting virtually or be here. And when we call for a public comment, they come forward.
So on the Zoom, they would come forward with something in the chat
That's right.
saying that they want to.
Or put their hand up.
Here. And then is there a limit to how many of those 3-minute things we're gonna have?
Well, it's a 15-minute public comment period. People are limited to 3 minutes. So at 15 minutes, public comment is ended.
So it's people who get to the front of the room to sign up or to, okay.
We're happy to work on that process with the MAC, since this is all new to all of us.
Right, right. So, my last question is, there's nothing in here about the MOAB or about the requirement that the MAC have a representative on MOAB as the Medicaid Oversight Advisory Board. And I wonder if our bylaws ought to reflect something about the MAC designated person to meet any legislative requirement.
My only concern about that is if the MOAB requirement is the state statute. There's a state law that requires the chair of the MOAB to be appointed.
Right.
I am concerned about putting something in our bylaws in case there are changes to the MOAB, to the state statute. So the requirement comes down from the state law, not from our bylaws.
Yes, I think I was thinking about referencing it more than anything, because I think it should be something that we talk about at the MAC meetings, for one thing.
Well, it certainly could be a regular agenda item to talk about it. But it's the state law that requires the the MAC chair to be a member of the MOAB.
But the MAC is also in state law.
It's a beautiful marriage between state law and federal regulations.
So you're
not all of the MAC is in state law.
Well, that's true. I mean, so you're not in favor of putting any reference to it in the bylaws, is what I'm hearing.
This is your committee. If there is an interest in the members adding something to that effect, I worry it will begin to conflict if something happens and the legislators decide they're going to disband the MOAB and they're going to create a Medicaid Advisory Oversight Committee. And then there's no longer a chair sitting on the MOAB because the state law has changed. That's my.
And I was thinking about more general description when required by state law for a representative of the MAC to serve or something like that.
Okay.
Emily, I see you have your hand raised too.
Yeah, I think that the bylaws should be able to reflect both federal and state laws. If there's a conflict, we need to deal with the conflict always between federal and state law. But if there's also a future change in state law, we can update the bylaws to reflect that as well, because bylaws are something that can be revised ongoing. So that's how I would personally handle it.
I would agree with that.
Okay, noted to take that back, yes. Okay. Further questions or comments? Okay. So a couple things that I've noted just in summary is that we will have the transcript as notes options, but we do need to confirm a process of summarizing those notes to have a more easily useful summary from the more traditional minutes. I tracked a couple of the specific notes from page 4 and page 5 that Dr. Schuster mentioned. We can confirm, we'll check again at the quorum and voting language to make sure it's confirmed. We can add in inclusion of the role of a designee on the MOAB. And then I think I might be missing a couple things, but I'm confident it's in the transcript and in the notes that my colleague Amanda is tracking. All right. So at this time, I think we may need to make those edits or before we confirm for voting and handle that at our next meeting. Is that correct?
That makes sense.
That's correct.
Yes. Okay. Thank you. All right. So at this time, we can turn it over to Commissioner Lee to have a report out on a couple items that were requested from MAC members. And Commissioner Lee, I can move your slides for you. So.
Okay, yeah, you can just go to the next slide then. Okay, House Resolution 1 updates. Now, Helen, is this the only slide or do we have slides?
Nope, you've got slides throughout.
Okay, let's just get right to them. So House Resolution 1, do you know it was passed July 4th of 2025. It goes by various names, the OBBA, which is one big beautiful bill, but we refer to it as House Resolution 1. And it does make some pretty significant changes to Medicaid taxes and also to Medicaid, including how it's funded and how providers are paid. One of the biggest changes is related to, I'm sure you all may have heard, we have, let's see, I'm getting out of order here, but I want to talk a little bit about the Hospital Reimbursement Improvement Program. The Hospital Reimbursement Improvement Program is a program that allows the Medicaid agency to pass certain funds through to the Medicaid managed care organizations, and they in turn give those funds to the hospitals. It's called a directed payment or a pass-through, and the hospitals pay the state share of that funding. That equals to about $5 billion each year for both the hospitals and the teaching universities. That amount of funding will be reduced over time to 100% of the Medicare fee schedule. So that will have a significant impact on our hospitals as we go forward. But it also, the other changes related to eligibility, it does limit retroactive coverage from 3 months to 1 month. Currently, individuals can come into the program when they apply. They are asked if they have medical bills, for example, and if they do, we can make their eligibility retroactive for 3 months to help them with some of those medical bills and make sure that our providers get paid. But for expansion members, that is going to be limited to 1 month, and for our traditional, pregnant women, children, aged, blind, disabled, is going to be 2 months. It also limits eligibility for certain lawfully residing individuals. And it requires our Medicaid expansion members to have their eligibility reviewed every 6 months, beginning January 1st of 2027. Currently, we typically do some redeterminations, or we look at information to verify. We do have an integrated eligibility and enrollment system. And we have access to various data sources that helps us ensure that individuals who are enrolled in the program still qualify. But we're going to have to actually do a redetermination for those individuals in the Medicaid expansion portion every 6 months. It does require those Medicaid expansion members aged 19 to 64 to be subject to work requirements or community engagements beginning December 31st of 2026. We have, if you all may know, that we submitted an 1115 waiver to CMS before this rule was finalized, before House Resolution 1 was finalized. We are not in compliance with the guidance that came out in House Resolution 1. We will have to be re-examining that process and how we design the program going forward. But we do know, based on what we have looked at, and we believe the numbers are still pretty accurate, that out of the over 400,000 individuals that are in the Medicaid expansion program, that the majority of them are either working or they are in an extended group, such as a caretaker of an individual, or they are receiving treatment for substance use disorder. And out of the over 400,000, we've identified a little over 70,000 individuals that we think will be subject to the community engagement or work requiring activities. And that is a there's going to be a huge lift for us that we're going to have to start thinking about very, very soon, given the start date of December 31st, 2026. House Resolution 1 does say that that states can request a good faith exemption and push that out for a year. But we have also been informed that CMS has in public forum stated they will not be issuing any good faith waivers. We are going to have to re-implement some cost sharing for our Medicaid expansion members beginning in 2028. So you can see some of these dates are out into the future, but we are going to have to implement some cost sharing requirements for those individuals with income between 100 to 138% of FPL. This is something that we haven't really looked at, haven't analyzed yet. We used to have cost sharing in our Medicaid program, but in 2020 or 2021, all of that cost sharing was eliminated. And we previously had cost sharing for non-emergency use of the ER, a few other provider types. We are going to examine what we had in place before, because all of these changes do require significant IT or information changes in their system, which is also a cost that was not included in House Resolution 1. So we are going to look at what we had in place before to see if there's anything we can use, but you can see that primary care, mental health, substance use disorder services, family planning, ER, and long-term care services, and services provided by certified community behavioral health centers, federally qualified health centers, and rural health centers are exempt from cost sharing. Next slide, please.
Excuse me, Commissioner,
Yes.
when you talk about the cost sharing, are you talking about like the $3 copay that people used to have to pay?
Yes, and in some of these provisions, we are still waiting on CMS to give us some guidance on how this is supposed to look, or some of the guidelines around. For example, there's some questions related to work requirements and community engagement, and how we validate those, and can we take self-attestation, and what does constitute as community engagement, for example. So we're waiting for some of those parameters. And that can go right into our Rural Health Transformation Program update. And you can go to the next slide, Helen. You know, the Rural Health Transformation Program is outlined in House Resolution 1. And do we have another slide for that one?
No, this is just the placeholder for the updates you were going to give.
So the guidance for this, we actually, in July of this year, we put out a letter to many stakeholders asking for input into what a rural health transformation project would look like. We did receive a lot of information. And then in September the 15th of this year, CMS came out with their guidance. And so then we got to see what we could actually, how it was supposed to look. And we pulled together a team. And so we had 4 weeks to pull together a transformative program that's going to impact the health of this state for many years. And we have four weeks to do that. But I believe that we have done a very good job, and the application was due November the 5th. And so we were very concerned about everybody submitting an application on November the 5th and having issues with our system and not getting in. So you all are the very first to know that our application was submitted today. We got it in. Yay, we have our application in. We do believe that given the timing that we had and the input, we believe that we have developed a very good application focused on I think 5 areas that we believe are key areas to us transforming the healthcare of the state, and such as maternal health, behavioral health, chronic disease, even oral health. So prevention, So as I'm sure the next MAC meeting will have some more information that we can develop on that. But the funding breakdown is there's $50 billion that will be delivered over 5 years to all 50 states. The territories, the 6 territories are excluded. So that's about $10 billion per year for 50 states for the years 26 through 2030. Now, if you remember what I said a few minutes ago about how our hospitals were receiving about $5 billion a year, that's not really gonna even over the course of the year. That's why this committee is so important to help us track what's going on in the Medicaid program as we move forward with some of these changes that we have to implement at the federal level. Your input, your insights as providers, as utilizers of the services are going to be so vital. So 50% of that funding, 25 billion, is going to be distributed equally among all states with an application. So 25 billion will go to all 5 states. The other 25 billion is going to be allocated based on factors such as your rural population, your rural health facility proportion, and situation of specific hospitals. And we believe that there are some rural hospitals that are maybe either looking at transforming some of their services or actually closing depending on funding. So again, we have submitted our application today, yay. And we believe that the CMS is going to announce the awardees by December 31st of 2025. So before I move on to waiver updates, are there any questions that you all may have about either the House Resolution 1 updates or the rural health transformation? That is a lot of information.
Yes, could you share with us the application that Kentucky sent in? I know there's a lot of providers who are interested in that information and how that might affect us.
Yeah, we will take that back and see. I know that we have submitted it. I think it becomes a public document when it's submitted or when it's approved maybe. So we'll definitely have that and more information at the next MAC.
Okay, thank you.
When are you finding out? We will find out by December the 31st of 2025. It's when the awardees will be announced. And we believe that every state has submitted an application, but we won't know that. So definitely at December 31st, so at the next MAC, we can have a summary if you want. We can have a summary of what was in the application, and we were limited. Do you remember, Commissioner Marks, how many pages? We had a limit on the number.
Very short.
It was very short.
Painfully short.
But we will have that at the system. Since we will have information from CMS by December 31st, we will have more at the next MAC meeting with the summary. Now, do we have anything on the waiver updates? So we have 6 1915C home and community-based waiver programs in Kentucky. A home and community-based waiver it just complements the coverage available under the Medicaid state plan. I typically say there's almost 2 Medicaid programs. One is for individuals who are enrolled in Medicaid and have benefits through a state plan. And then our other program are those home and community-based waivers. Those are services that are designed to keep individuals in their home and community rather than in an institutional setting, such as a long-term care facility or a residential home.
Sounds like
There must be a unit over here. There must be something in the air. So
that public health over there.
I know this building is quite old. So we do have a process to determine who's eligible for services. There are certain federal requirements that states have to abide by in order to deliver those home and community-based waivers. it has to be budget neutral, which means the cost of providing those services in the home or community has to be equal to or less than services in a facility. And we have to ensure that the quality of services and support the individuals receive. So we do have to meet those requirements in order to receive those federal dollars for the 1915C programs. Next slide, Helen. So we currently have 6. We have we have 6 provider types that have different criteria. For example, acquired brain injury, or for individuals who have acquired brain injury. The other waivers are for individuals varying ages who have severe emotional behavioral health or developmental disabilities. Next slide, Helen. So waiver services offered again are traditional, which is individuals who are enrolled in a waiver program can receive services by providers in the community. We also have participant directed services. This allows individuals to hire for people that they know, such as their friends, family members, who are legally responsible for the participant, and they undergo a review before they're hired. But these individuals don't provide medical services. They provide personal needs supports, for example. And so then you have some individuals who have a blended, and they use either the traditional and the participant directed services. And this is based on a lot on the member, based on their preferences, their personal needs, and also the workforce within their community. The participant directed services does allow them to hire individuals that if there's a shortage, for example, in their area, they can't find someone to come in with their homemaking or their personal needs. They can designate an individual through the PDS program that will allow them to get those services in a more timely fashion. And we do have some numbers down there. So 2025, we have 14,467 participants across their waivers, except for the Model 2 waiver that use PDS or blended services. So we have a 1915C child waiver that was recently submitted to the Centers for Medicare and Medicaid Services. So the child waiver is we're calling it the Community Health for Improved Lives and Development for Child, because we would not be a Medicaid program if we did not have acronyms. So the child waiver is new. We do have, like I said, those 6 home and community-based waivers, but this is new and it's targeted specifically for children and youth with significant behavioral health and developmental challenges. And we want to make sure that they get the needs, get the help that they need in their home and community. As you know, again, I said we serve over 600,000 children in the Medicaid program, and some of our most challenging are those individuals with significant behavioral health needs. And in addition, our 1915C waivers are full and we have individuals on a waiting list. So we are hopeful that this child waiver will help identify and serve some of those individuals who are at most need right now under the age of 21. So again, it's going to be focused on children and youth with that are stepping out of acute inpatient care at risk of out-of-home placement that requiring intensive behavioral health and residential supports. It will include clinical therapeutic services to foster that step-down approach. The idea is that we get them into a child in care when they need it most, and we can continue to provide those services. And as their health continues to improve, and they can be either reunited with their family or start receiving services in the more traditional setting, that they will kind of step down out of that waiver, and which will help us serve hopefully many more children through the waiver, as those with complex needs hopefully get the care they need and maybe move to a lower setting of care that outside of the waiver. Next slide, please. So here is just the criteria for the child waiver. They have to be under the age of 21 with significant behavioral health or developmental needs. And it is for Kentucky children and youth who need a level of care similar to what would be provided in an inpatient facility, an intermediate care facility, or a hospital. So we also want to be able to have these children safely supported at home or in the community with the right services to meet their needs. Next slide. And then we have a 1915I service. This is a little bit different, even though it is a waiver. It more resembles a state plan amendment. And so the difference between a 1915I and a 1915C is a 1915C is, you have parameters around that 1915C. So for example, we have a waiting list for our individuals in some of our waivers, specifically home and community-based supports for community living in the Shelby. But this 1915I we will not be allowed to have a waiting list. It more or less resembles a state plan amendment. It has to be open to anyone who would qualify for that waiver. And so we're calling our 1915I waiver the RISE initiative, RISE standing for Recovery, Independent Support, and Engagement. Dr. Schuster, how long have you been advocating for this waiver for?
Oh, I think Steve Shannon and I have been advocating for 20 years for this waiver. So it did 5 years on this particular one to get it to this point. So, yeah.
And so it's an initiative to provide services to adults with a primary diagnosis of severe mental illness or co-occurring severe mental illness with addiction. It is a SPA that is administered by the Department for Behavioral Health, Developmental, and Intellectual Disabilities. Commissioner Marks and I had a good conversation about this today, and we're very excited about all of the promising things that we see coming down the pike. And this was created to, as you can see, with Senate Joint Resolution 72. And so if you want more information, we typically have this as a standing update on our Medicaid Advisory Committee meeting. So we will have this as a standing update on future meetings with progress and what we are seeing as we go forward. Next, thank you. Yes, and Commissioner Marks, I know we don't have you on the agenda, but was there anything that you wanted to?
Just that we are really excited about the innovation of this, and the priority right now is recruiting providers to go through the onboarding process. And so please reach out to us. We can provide one-on-one TA. Please refer providers that you think would be a great fit. We have to create capacity before we can serve participants, and so we need everyone's support.
Thank you. And this is definitely a partnership. We're so excited about what this waiver will be able to do. Here's just a list of services, and I think we're running a little bit short on time, so I won't read all of those to you. But we are excited about the services that these individuals will get, especially the housing and tenancy supports. Next slide.
I would just say that they're the services that we have been begging for years and years. Respite for the families that they had never qualified for respite before. And then the housing and tenancy, because that's the biggest need that families identify with their people with SMI. So we're super excited.
And we're just very thankful for all of your advocacy over the years and helping us design and get this to the finish line. And like you said, it's something that you've been working on for 20 years, something that's needed. And this is new. This is a 1959 waiver. So as we move forward with our Medicaid program, these are the kinds of things that we need to look at. What can we do to be innovative? What can we do to ensure that we're meeting the needs of our members and our providers within the confines of state and federal regulations, and what do we need to look at? And again, innovation is going to be so critical as we move forward over the next several years.
Thank you, Commissioner Lee. And I want to just flag a comment in the chat that came through, just noting there's interest in when we have more updates on the Rural Health Transformation Program and application, knowing Kentucky's approach to the future of rural hospitals and members in rural communities having to drive farther to get help, and sort of initiatives that'll happen for those communities as well, which hopefully we can have additional updates in future meetings and share more then too.
Thank you.
Okay. Thank you so much. Now we have, also, I was wondering if there's anybody on, from the RISE Initiative team that could share contact information. That would be lovely too, or we can follow up with it, afterwards as well.
Yeah, we can follow up with that afterwards.
Okay, thank you. All right, now we have, Dr. Judy Terrio to give us a maternal infant health update. As requested, I believe these have been provided before, and, we have another one to share with you all.
Hello, everybody. Hopefully I will present some very interesting and new information to you, not recapping old stuff. So next slide. We'll talk a tiny bit about birth data, recent birth data, who is giving birth, how they're giving birth. Then we'll go into some access issues, especially in the rural areas. Talk a tiny bit about the 2024 maternal mortality report, which is the most recent one we have. They usually come out in November. So before the end of the month, we'll be getting the 2025 report. We'll talk about infant mortality and then some of the current initiatives that we're doing in Medicaid. So next slide. This is some birth certificate data. And for the Kentucky numbers, we're in blue, obviously. And then there's United States numbers in orange. The Kentucky data is from birth certificates from 2023 and 2024. And just thinking about who in our state are giving birth, about a quarter of the moms are younger than 24, which is lower than the national average. Then the largest group of moms is between 25 and 39. That's typical, although nationwide, there's more moms in that age group than in Kentucky. We have a smaller percentage of moms older than 40. And then when we look over to race, most of the moms in our state are white, so 80%, which is a lot higher than the national average. And this is really just based on our overall demographics for the state. About 9.6 of our moms are Black African American. So next slide. These are Medicaid data, and this is from our maternal health dashboard, thinking about how are moms giving birth. Talked about the who is giving birth. Now, how are they giving birth? Well, if you look at the totals over on the left, about 36% of our moms give birth by cesarean section, which is more than 1 in 3. And then when you break that down, how many are having a C-section for the first time versus a repeat C-section? About 29% are first-time moms with C-sections, and 7% or so are repeats. When we break that down by race, we see that it's higher for our Black women, so 38%. So that's kind of a big difference, 2 whole percentage points higher for our Black moms giving birth by cesarean section. And then breaking it down, almost 31% of our Black moms that give birth for the first time are giving birth by cesarean section. And then the reason that we keep track of these numbers is obviously if you give birth by cesarean, you're much more likely to have your second or third or more babies by cesarean. And so it's kind of setting you up for that trajectory. Also, if you give birth by cesarean, it's much more risky. You're at increased risk for any other type of morbidity or mortality. So hemorrhage and infection and all that is kind of wrapped into the higher risk of having a cesarean birth. So ideally, we would like to see those numbers go down. Next slide. This is the national versus Kentucky data again, and these are our low risk C-section rate. So that NTSV means it's a first-time mom, it's a term baby. There's only one baby in there. You know, we're not talking about twins. And the baby is head down and ready to come out. So no breech baby. So this is nationwide what we call the low risk C-section. When you look at that, our totals are higher than the nation as well. So 28% of our moms of our new moms have C-sections, but they have no risk for it. And that's higher than the national average. Again, when you break it down, almost every category were higher. And then white versus black, it's more than, it's about 2.5% higher for our Black moms in Kentucky than our white moms to have one of these higher risk births. So next slide. Now, what's our landscape look like for our maternal health workforce? This slide is from 2024, and the stars are where birthing hospitals are a county with at least one birthing hospital. So we have a total of 46 birthing hospitals. And for example, Jefferson County only has one star, but they have several birthing hospitals in that county. So you can kind of get an idea of where these birthing hospitals are spread out. And then the numbers are the number of the maternal care workforce in those counties. And obviously the counties with nothing, they don't have anything there. So this was 2024, and now let's look at 2025. And you can see it's shifted. We, for example, in Harlan County, maybe make one more press, see if that circle shows up. Oh no, we'll go back, sorry. So in Harlan County, down at the bottom where it says 5, bottom right, we had a star there. But in February, that hospital in Harlan closed their labor and delivery unit. And so we had to take that star away. So they still have some practitioners that can care for pregnant women, but they no longer have a birthing hospital there. Breathitt County, which is the red arrow pointing at this bigger county with nothing in it, that county lost a practitioner. And so these are, kind of rapid changes. The other arrows are pointing to counties that actually gained a practitioner. But it's fluid. There's a lot of holes in the state with practitioners and with hospitals. And so this is something we're watching very closely. So next slide. We've adapted this map from March of Dimes map. And we looked at trying to normalize the data and look at the practitioners as a rate. What we found is we could divide the state into counties that have full access, low or moderate access, and then those in red that we called maternity care deserts. And so full access have one or more birthing hospitals and greater than 60 maternal care providers per 10,000 live births. So this is a full access county. Move on to the red ones that they have no birthing hospitals and they have less than 60 providers per 10,000 live births. And you can see more than half of the counties in the state are these red maternal care desert counties. So what does that mean? So next slide. When we look at how long does it take, what's the distance to a birthing hospital? The darker blue counties have the longest way to go. So the ones across the bottom of the state, and then way over in the mountain area, you can see have a lot longer distance to go to get to a hospital, a birthing hospital, not a provider, but a birthing hospital. And next slide. And when you look at that, just lumping them all together, comparing rural to urban, you have not quite twice, but a good amount more to go in the rural areas. Now that makes sense, but it's not interstate driving. You can't just get on the interstate and know you have exits along the way and get to your hospital. It's country roads, it's dark, it's 2-lane highways. So it's not easy driving to get to some of these hospitals. And so the fear is, just like in Harlan, who closed their labor and delivery unit in February, the hospital might remain. The rural hospital, is going to be struggling. They're struggling now. It's going to be struggling more in the near future with funding. If you're trying to keep the hospital afloat, you might have to take a hard look at the services you provide, and that might mean closing an L&D unit. And so the hospital might remain, but the services to pregnant women may be closing. And so we're watching that closely and just to see how things work out and trying to be a little bit proactive. So next slide. Now, we talked about the maternal mortality report that comes out every year in November. How that comes about is there's a maternal mortality review committee, and that committee examines in great detail all maternal deaths during pregnancy or within 365 days of pregnancy, taking a deep dive into each one of those cases to look at possible causes, were they preventable? You know, what happened to cause this death? Because obviously the deaths are with primarily young women that are healthy. The committee is made up of physicians, public health, Medicaid, DCBS, doulas, midwives. So there's a lot of people in on this committee to really delve into the cases. Next slide. And so some of these numbers are from our maternal mortality review committee. The orange again is United States averages, and this is just looking at the mortality rate per 100,000 live births. And you can see Kentucky is in blue, and we are higher than any of those past years for the United States. So next slide. From the report, and we can track the total number of deaths along with the rate of death. And you can see that it follows along, which makes sense, the two of them, but it's going up. It's getting a little bit higher and higher. So again, not that great, but it's something to keep your eye on. So next slide. These are looking at, when you look at the maternal deaths, you can look at all of them that we just did on the last slide, or you can break it down and say, okay, which ones of those deaths were pregnancy related? Meaning if the mom wasn't pregnant, the death wouldn't have happened, pregnant or postpartum, versus a death of a woman in that same time period that maybe was an automobile accident. So that would be associated, you know, pregnancy associated versus pregnancy related. So when we pull it out and just look at the pregnancy related deaths, the ones caused because the mom was pregnant, there's a lot fewer. So you can see in 2020, there were 11 deaths caused by the pregnancy, and the rate was 21.2. So these are bouncing around. They shouldn't happen. These are the still shouldn't have happened, but some you can argue that were not preventable. But we keep track of that and we look at those a little bit different. So next slide. These are the, I think we went a little bit back there. Oh, keep going the other direction. There you go. When we break things down, these again are the pregnancy related deaths, and we look at it urban and rural. It's interesting because in Kentucky, it's flipped compared to the national averages. So we have a lot more pregnancy related deaths in our rural areas than the nation does. And that is something to keep an eye on, especially with our worries about rural healthcare and women's health in the rural areas of the state. So next slide. So those pregnancy related deaths, does somebody have a question?
Nope, I think just.
Oh, sorry.
Continue.
Okay. So the pregnancy related deaths, what's causing those? Because I just said these are young women. Well, primarily cardiac conditions cause those deaths. So you can get a cardiomyopathy, an endocarditis, even have a heart attack, congestive heart failure, all during pregnancy. So that's the majority of those deaths. Other things are embolisms, blood clots, sepsis, hypertension, things like that. That's what's causing those deaths. Next slide. Just because I knew somebody was going to ask, we pulled out accidental deaths due to a drug overdose, and this is from our report again, and you can see those are continuing to go up. So in 2022, 73.9% of accidental maternal deaths in our state were caused by a drug overdose. So next slide. And then just looking at the deaths per ad district or area development district in the state. And again, this is just where are those deaths happening? Kipta and Bluegrass have the majority, and that's because more people live there. And then in Northern Kentucky as well. But you can kind of see where the deaths are happening. Next slide. So the key findings from the report that came out last November were 90% of the deaths were deemed preventable. 90% were preventable. 17% were pregnancy related. 58% happened between 45 days and a year after the pregnancy. So we call those late maternal deaths. So if more than half are happening after you're no longer pregnant, you've gotten through the labor and delivery, you would think you were home free, but you're not. That's when most of the deaths are happening, 43 days to a year. 3 out of 4 of the moms had Medicaid funding, which is a lot when you think about only 50% of the moms in Kentucky are on Medicaid when they have their babies. And then about half of the deaths had substance use as a factor. And these are from this past report. Next slide. So some of the things that are happening to try and combat that, we have our Kentucky Maternal Mortality Committee, and that kind of gave birth to the Maternal Morbidity and Mortality Task Force. And the reports that come out every year have recommendations. So that the job of the task force are to take those recommendations and try to put action to it. What can we do to help? What can we do to, make these recommendations come true so we can fight maternal mortality. And then the Kentucky Perinatal Quality Collaborative is it's a quality improvement group that is going into birthing hospitals and doing quality improvement activities. So, okay, you have a lot of hypertension. What are you doing? How are we following the moms? Are they coming back in for their follow-ups? Are they getting medication? Are they getting evidence-based care? And so that's what that group is doing. So we're trying to hit it on different levels to try and improve the health of moms in the state. So next slide. Another thing that's just started is the Kentucky Consultation and Outreach for Maternal Psychiatry Support Services. This is an outreach number that providers can call. So if you've screened a mom, she screens positive for a mood disorder such as depression, and let's say you're a pediatrician or just an OB and you don't know how to treat depression, you don't have you don't know what to do, you can call this line and get advice from a mental health specialist, and you can either get the mom to the services they need, you can start medication, you can do something. But this is a service for providers to help treat moms with evidence-based care. And this has just started, and it's been started with the help of a grant that Public Health has received. Next slide. Switching gears to the babies really quick. This is a graph that shows a bunch of different countries, and the United States down there at the bottom, and this is the infant mortality rate. So the infant mortality rate in the United States is 6.1, and it's much higher than every other country listed there. So next slide. When you're looking just at Kentucky, you can see that on the left side, our rate is higher than the national average. So our rate in 2023 was 6.7 per 1,000 live births, and nationally it's been about the same at 5.5. So this is not good. So we are having a bigger problem with infant deaths, and an infant death is between birth and 1 year of life. That's what we are calling an infant death. When you look at the mortality rates per 1,000 live births in the ad districts, you can see Kipta is kind of close. Kipta is where Louisville is, and that's our biggest population. It's 5.6, which is very, very close to the national average. But when you get outside of that area, so Big Sandy is way over by Pike County, and their rate is 13.1 per 1,000 live births. If you go the other direction, you're heading west over to Pennyrile, that is 11.1 per 1,000 live births. So we have a much higher mortality rate for our babies in the rural areas of the state. So next slide. What's causing this mortality? Well, in Kentucky, it's sudden unexplained infant death is the #1 cause, and that includes SIDS, which means we don't know why the baby died after investigating. It also means suffocation, unsafe sleep. So they kind of roll these together into one thing. The second leading cause in Kentucky is preterm births. And then congenital malformations, perinatal conditions, and unintentional injuries. So we're going to look a little bit closer at why our babies are dying. So next slide. For Kentucky, in Kentucky data, about half of the babies are dying with either the SUID or the preterm birth definitions. So next slide. When you're thinking about SUID, that pie chart on your left, you can look at that biggest chunk. It's almost half of the pie chart. That's unsafe sleep. So the babies are dying because of all these red flags, or what do we want to call them? Risk factors for unsafe sleep. The gray area that's almost as big as unsafe sleep is suffocation. So, and I know you're thinking, well, how can this happen? Well, a suffocation can happen if a baby is put to sleep on a surface that is not appropriate, such as an adult bed, a pillow, a couch, a chair, and they can't, move around as easily as an older child or an adult, and they suffocate. Or they're put into bed to sleep with an adult or an older child, and the parent falls asleep, and then they wake up in the morning and the baby is tangled up in the bedclothes at the foot of the bed, or wedged between the wall and the bed, and they've suffocated. And so that's why we really harp on safe sleep, because this accounts for 30%, almost 1 in 3 babies in our state. So just to remind everybody, babies should be put to sleep on their back in their own crib with nothing else in the crib. You don't bundle them up with blankets. They're fine just on their back with nothing else. And that's the safest place for them to be. So next slide. When we look at SUID and unintentional injuries, we again, interestingly, see a lot in Big Sandy and in Pennyrile, but also going up to Buffalo Trace and into northern Kentucky. So again, it seems it's a problem everywhere, but it's a bigger problem in the rural areas. So next slide. Again, because I thought somebody was going to ask me, what about neonatal abstinence syndrome? So these are babies that are born exposed to drugs, primarily opiates in their system. And if you look, our rate in Kentucky is 15.2 babies born with NAS per 1,000 live births. The United States rate is 5.9. So overall, our state is much, much higher than the national average. And then when you break it down by ad district, you can see the far eastern part of the state is much higher. For example, Kentucky River is 49.7 babies per 1,000 live birth, which is a huge number. And Big Sandy is up there at 36.1. So not so much over on the western side of the state, but in Appalachia and the eastern part of the state, we have a lot of problems with babies being born exposed to substances. So next slide. So what was the second leading cause of infant death in Kentucky? It was preterm births. When we look at the United States compared to other nations, we're at 9.8, which is much higher preterm birth rate than the other nations. Next slide. And when you look at Kentucky's, we have kind of, for the last 10 years, been straight across the board, right around 11.5 or so. So in 2023, we're 11.3. So that's a lot higher than national. Next slide. And, you know, what does it look like when we break it down by race and ethnicity? Well, our white people, which is 80% of the births, it's 11.4, so that's the state average, still 2 percentage points higher than the national. But our Black moms, 14.5, our Native American moms, 14.3. So these are much, much higher than not only the state average, but way much higher than the national average. So next slide. We have some disparities going on there. We are working with our Department of Public Health fellows over there on a lot of different issues. And we have a new maternal health division within Medicaid. And Mindy Gathoff is a lead on an affinity group project that we're working on, trying to increase the use of our notification of pregnancy forms. Because if we know a mom is pregnant early on, we can help connect her to services. We know that preterm births are much lower for women that are getting appropriate prenatal care. And so there's one way we can attack our infant mortality rates. So we're working on that. We're working on blood pressure and mental health issues. Again, some very important health things going on for our pregnant and postpartum moms. We've worked on the maternal health, mental health governors fellows. We have a value-based purchasing program trying to, with our MCOs, trying to improve postpartum care measures, national measures. We're working on a maternal desert policy academy to help increase care and improve care in the rural areas of the state. Last year, we did a focus study. Actually, it was 2025, I believe, not 2024, on disparities in postpartum care, that we have some data that we can work on. And we're working on our first Medicaid maternal health report that we plan on continuing. That will come out soon. And an annual maternal health resource guide. And that is a guide that sums up all of the MCO's value-added services for moms, and presents it in a way that it's easy to see based on your MCO what resources you have available to yourself. We've made one for 2024, and we're currently working on the one for 2025. And this just makes it easier for moms to know what they have, what they can possibly use. So I think that's it. So we've got go ahead. We've got a lot going on.
Thank you so much, Dr. Terry. We really appreciate that. It was great information. It sounds like there's a lot of reports online. We can share that report in our follow-up email as well, the link that was in the slide. So thank you so much. We are a bit behind time, so I'm going to continue us on. At this point in the meeting, I want to go ahead. We collected some recommendations from the TAC representatives, and we received a couple, one from the IDD TAC. Do we have the chair of the IDD TAC on? I welcome them to come on and present their open recommendation to the MAC regarding the proposed revision to language around the involuntary termination of waiver services.
Yes, Helen. My name is Wayne Harvey. I'm the chair of the IDD TAC. Good afternoon, Dr. Schuster. Congratulations on getting appointed back as the chair of the MAC. We enjoy you being in charge and helping us move things forward in Kentucky. To summarize things really quickly, instead of reading through paper and stuff, because I know we're short on time, what we presented as a recommendation to the MAC, and Dr. Schuster has a copy of the recommendation itself, is simply a response to DMS's letter back to us requesting information on 4 different areas around involuntary termination. And that's what we've done. We've accumulated some information from our different TAC members, formulated that all into one document, and submitted it for approval from the MAC to be submitted back to DMS.
Wayne, I had a question about it. Does it look
Sure.
like it looked like it was written like it was a regulation? Is it an
Yes,
adaptation or revision of a regulation?
No, it was written that way because it was easier to deal with the information itself. Dr. Schuster, it's not meant to be taken as regulation or anything of that nature. We thought that DMS staff themselves, since they're so used to dealing with regulation and so forth, would be able to read through it a lot quicker in that format and be able to determine whether or not it was going to be useful in looking at change in policy or if it wasn't going to be useful.
So you wrote it in the form of a regulation, but it is not actually you're not proposing it as a regulation.
No, it's simply information that they requested from us in reference to looking at policy change. The format itself was written that way just because it was easier to look at what the current regulation was and, you know, add the changes in that we thought might be useful. We're not proposing that as the change itself. We're just saying that this is information that they asked us to gather in relation to 4 different areas. And that's what we did and submitted it for them to review and let us know if we can be of further assistance on the matter.
All right, thank you for that clarification. So you're responding to the letter back that you all got from DMS.
Yes, just for clarification, Dr. Schuster, they asked for information around four different areas from us, and that's establish exceptions for critical safety concerns, define transition planning requirements, implement provider support structure or measures, and conduct stakeholder engagement. And we feel like the document that we put together and submitted for approval to be submitted back to DMS covers the different areas that they asked for feedback on.
And that was approved at an IDD TAC meeting that you had a quorum?
Yes.
Okay.
It was approved at our October 7th, 2025 meeting.
Okay. Thank you.
You're welcome.
All right, we can move on to the next recommendation and deal with the voting to move forward with all at the end. Do we have the chair of the nursing facility TAC on? I believe they had 2 open recommendations to present.
This is Terry Skaggs. I am the chair of the nursing facility TAC. And yes, we did have 2 recommendations. The first is on the clocks modernization and PACER implementation. The TAC supports the modernization of the clock system, but recommends 2 key modifications to ensure timely hospital discharges in compliance with the federal PACER requirements. We're asking that you allow flexibility in the level of care determinations to reinstate the prior 3-day window post-admission for the level of care approval rather than requiring that it be met, have a met status prior to admission. This would prevent unnecessary hospital delays and improve resident access to care. And the second part of that is to expand the PACER authority to amend Kentucky's PACER regulations to allow additional qualified providers such as hospital clinicians to complete level 1 screenings, aligning Kentucky with peer states and facilitating the federal compliance prior to admission. The second item, earlier in the presentation, when you were discussing HR 1, talked about the traditional Medicaid applications, the retroactive eligibility moving from 90 days to 60 days. We are requesting that DMS review and report current processing timelines for long-term care Medicaid applications to establish a baseline for improvement. We ask that DMS identify actions underway to ensure determinations occur within federal required timeframes and that coverage gaps don't jeopardize resident care or facility reimbursement stability. Currently we are able to have our residents receive a 90-day retroactive eligibility, and that is moving to 60 We are having issues even being compliant with the 90 currently. So we've been talking with Medicaid and did bring this up in our September 3rd meeting and sent these recommendations forward.
So that was your September 3rd meeting, and you did have a quorum at that meeting?
We
Mary?
did. We did.
Thank you.
All right, if no further questions, I welcome the chair of the primary care TAC to present the 2 open recommendations that you all have.
Good afternoon. This is John Lillybridge. I am the chair of the primary care TAC. We did have 2 recommendations from our October 23rd meeting. The first was for that DMS, MCOs, excuse me, and interested provider groups collaborate to develop an enhanced process for tracking and communicating eligibility and enrollment information to providers. And the goal here is to enable more seamless patient engagement. Our second recommendation was that is for DMS, MCOs, and providers to form a work group to explore ways to streamline value-based programs. And this would hopefully include operational efficiencies, some common reporting structures to reduce variability among MCOs, and then of course to improve provider and patient experience. So those were the 2 recommendations that came out of our last meeting.
Thank you, John. And did you have a quorum at that meeting, sir?
Yes, ma'am, we did.
All right, thank you.
Wonderful. Dr. Schuster, would you like to ask to move these forward for approval?
Yeah, our typical process has been to get the reports together. And then I'll ask for a motion from someone who's a voting member of the MAC to approve sending the recommendations onto DMS. And I want to clarify, this is a good example. We're not asking MAC members to approve the content of those recommendations. We're asking for the MAC members to simply approve that they be sent on, since they were arrived at by a duly appointed TAC meeting with a quorum and sending the recommendation to us. So I would entertain a motion from a voting member of the MAC that we approve sending on these recommendations from these 3 TACs onto DMS.
I'll make a motion.
I'll second.
A second.
We've got 2 here. Barry Martin made the motion and Zach Hart has seconded. And they're in my line of vision, so if that's all right, I appreciate that. Is there any discussion? If not, all of those who approve the motion, please signify by saying aye.
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 And any opposed? And any abstentions? Then we will forward those recommendations. Thank you. And I think, Barbara, you have those recommendations in writing. Do you?
Yes, I do.
Oh,
I'm ready.
there you are. All right, great. Yes, thank you. We will forward those recommendations. Thank you.
Wonderful. I know we are at 4 o'clock, but we do want to ensure that we allow time for public comment. So if there's any in the room or those on the Zoom, please do feel free to raise your hand. Members of the public, you would have time to share any comments or items now.
Do we have any new business? We seem to skip that.
None was shared ahead of the meeting. Yeah. Okay. Please, we can continue. I know I'm not seeing any hands raised, but as I will keep an eye on that. But in the interest of time too, I know one of the big things we want to talk through today is the future meeting planning. On the next slide here, I have the schedule of the BAC meetings. These are Mondays. They are every other month the second Monday of the month. They meet every other month, and they must meet before the MAC can meet. So an option would be to meet every other month. You can continue at this time, this being the first Monday, 2 o'clock to 4 o'clock, or you can shift. I know MAC meetings previously were Thursday mornings, so if we want to shift back to that time, if that remains an option or a good meeting, just considerations. MACs must meet before BACs. After BACs. I keep saying it the wrong way. They'll be 2 hours long. Then just remember that there are MAC members who also serve on the BACs. This will make it so that they have monthly meetings. Attendance is going to be monitored, and we're going to be understanding, I know that the quorum issue was dated as we were talking about, but if it comes back, we might need to assess that too.
How was the decision made that MAC meetings will be 2 hours? That's an hour shorter than we've been meeting. And I am very concerned that we won't have time for all of our 12, 13 tax to report.
Yeah, I think that was. So I think that this was in an effort to understand the capacity and commitment across all members, and limit sort of the time out of the day, but I welcome other inputs as well too.
This is Nina. I think we've needed that extra time to be able to get through all the agenda items, and when we're done, we're done. So if it's earlier than 3 hours, which is what we've had, that's been fine too. But I share Sheila's concern that 2 hours may not get it done. I mean, today we just talked about TAC recommendations, and sometimes there's TAC business to discuss that may not yet qualify for a recommendation. At least that's my opinion.
I agree. I think we need to have at least 3 hours.
I agree also.
Yeah, 3 hours, but have it quarterly.
Barry's suggestion is 3 hours, but quarterly. There are so many issues that are going on, or I was looking at the last MAC agenda, and we fill those 3 hours, Barry, every other month. I really am concerned about moving to a quarterly meeting.
I was just thinking about the back members, because that's gonna put a lot on the.
And this the opposite month, because I'm a back member. I mean, that seems reasonable to me. Like, so back meets in January, we do February for this one.
So Zach here, I don't know if you all can hear him, it's a back member saying if they meet on the alternating months, which actually is a big change for the MAC. Because we've always met January, March, May, July, September, and November. So we're gonna be meeting in the alternating months, which will be a change. But I think that's a reasonable request. I think it would be very difficult for the back members to have a 2 hour meeting and then.
Is the Monday okay with that? Because that, I mean,
I would recommend going to Thursday. I think Monday's gonna be tough to get, especially the providers.
You know, Helen, I thought there was a poll taken, or you all gathered some information from both BAC and MAC members about best meeting dates. Do I not remember that? Did you all do
That was for this scheduling. That was for scheduling this meeting, the first meeting.
I know,
and then this
is still viable, right?
Well, it didn't include dates going into 2026.
But did it include, I was trying to remember, did it include different days of the week is what I'm asking.
No, it included specific dates and times.
Okay.
What is everybody else's thoughts?
Yeah, I would like to hear, you know, we had met on Thursday mornings. We used to meet 9:30 to 12:30 Eastern time.
and that's all right too, but just
Yeah, I don't
consistent.
know.
I don't know how much else goes.
Monday, Tuesday, or Wednesday is easier for me.
if you'd like to, Chair, we could do a poll across the members and get this feedback on availability. If that.
Yeah, we've got time to do that. I would rather do that. I'll work with you,
Okay.
Veronica. Let's do a poll. I want everybody to have an opportunity to think about. Let's think in terms of a 3-hour meeting. If we finish early, then you get that time back. But I think and let's think about alternating every other month, but we would be moving to February, April, June, so forth. And it will mean a meeting in December. So we ought to think about.
No, not this December though.
No, not this December.
Yeah, okay.
I understand.
Yeah.
The back is not meeting until January, right?
Mhm.
Right.
We did Thursdays, it could be the same.
Nina, did you have oh, sorry.
I did. Are future meetings going to also be available Zoom or in person? Are we going to continue with hybrids?
I think we were going to solicit feedback on whether we thought this worked. If we feel like it did, we definitely have that option.
Okay.
I'm gonna
Thank you.
bring binoculars next time.
Yeah.
Because it's really hard to read the screen from this distance. And we didn't have a lot of people that came in person. Right. And walking wise, I'd rather do Zooms, but we've had this discussion at the MAC before about occasionally having an in-person meeting and having it only in person, which would be kind of nice actually for the MAC members and probably for the BAC members if they wanted to do that. But with bad weather coming up, at least for in the spring, I would think that we would probably at least have the Zoom for sure. But why don't we ask that we'll ask that in the poll as well.
Mhm. Yeah.
So are we going to assume that we're going to be meeting in alternate months, so February and so on? And then
Right.
the poll is going to be for what day of the week?
What day of the week and what time of the day, morning versus afternoon?
Okay.
And will it also include questions about the length of the meeting?
I was
Yes,
getting a
yeah.
consensus for 3 hours, but maybe that's just maybe that's my selective hearing.
I think it might be a good opportunity to still offer that like a chance to say 2 hours works better for me
2
for those
hours
that
and
may not have had a chance to
okay.
raise their voice on this call, give them a chance
Yeah.
to share their voice too.
Yeah, that's fine.
Okay.
And we will
Well,
get
definitely
that
do that
out
poll.
before we get too close to the holidays so that people can, because I know for the providers on the MAC, it's very important that you all have that predictability in terms of your patient care and so forth. So yes, we'll do that. Thank you.
Yes, we want to get these on the books as soon as we can. Okay. So we will get that poll out, and in that meeting, in that email, we'll also send a link to, I'll just run through it quickly. We're going to have a feedback request. This doesn't matter. I'm going to make sure that you guys get this link to this survey so that you can answer all the questions. And then I just wanted to offer, and if you didn't catch that QR code, don't worry, I'm going to get you the link. So in closing, Commissioner Lee, is there anything that you would like to say?
Yes, I think this has been a very productive meeting, and I'd like to extend my congratulations to the officers and Dr. Schuster, Dr. Parton, Aisha. Just congratulations on being at the forefront of this very important project. I think as you've seen from House Resolution 1 and some of the challenges that we're facing, that the next 2 years are going to be critical. And I appreciate everyone's dedication to this program and being here to help us guide this program into the future. Again, 1.4 million Medicaid members depend on this program, over 70,000 providers. And we really need to do everything we can to make sure we're running this program as efficiently and effectively as possible to improve the lives of those we serve. So thank you all very much for me.
Thank you, Commissioner. Will we be getting the slides that were presented?
Yes, we can share the data slides, absolutely. Because there were a lot of charts and great information in them. And you'll
Yeah.
get,
And Commissioner Lee's introductory slides.
yes.
Yeah, thank you.
All right, thank you, everyone.
Well.
You
We can
Adjourn.
adjourn by acclamation.
Okay.
I had a question, Helen.
Yeah, absolutely.
I just wanted to make sure, one, that I wasn't going to be responsible for the minutes for this meeting, but
You are
moving
not.
forward. Okay. And then will I be sent the information, like as far as to take attendance and those things
Absolutely. Yeah.
beforehand?
Mhm.
Okay.
Yep.
And one more thing, I'm sorry. So just for my clarification, there will be a transcript, but I will need to summarize.
We are gonna take that back and confirm a couple things. I was,
Okay.
and we'll confirm that with you, Dr. Schuster, and Dr. Parton too, what works best and get like the right structure
Okay.
set up to make
Okay.
sure
And
that works best.
before our February meeting.
Absolutely. Mhm.
Okay.
Yeah.
Okay. I just wanna make sure I do it all correctly for everyone. Okay.
You're good. You're good. Yeah.
All
Totally
right.
get it. But yeah, you'll hear from us. And we'll we'll also be around for the February meeting to help with that too.
Okay. Okay. Thank you very much.
Of course. I hope you have a good day. Thank you for volunteering.
Yes. Bye.
Of course.